All right, in this video, we are going to touch a little bit more in detail about how these different cells are produced and some of the signals that trigger their production. All right, so we've seen this graph or image before when we did cells much earlier in the semester and talked about cellular differentiation, but we're going to talk a little bit more in detail about each of these different cell types now, especially now that we have a better idea of what it is we're looking at and what all of these words mean. All right, so like we've talked about already, most of these cell types are going to have a pretty short lifespan. There are some types of white blood cells, memory B cells specifically, that can survive for years, but the rest of these types of cells are generally only going to survive anywhere from a few hours to a few weeks. And so we do need to be constantly making more blood cells quickly and continuously. All right, so for example, if you were to donate a unit of blood during a blood drive or something like that, you're usually going to be able to replace the plasma within about 24 hours, but it can take up to 4 to 6 weeks to replace the actual cellular components and formed elements of the blood. And this is why there is a limit to how frequently somebody can actually donate blood. Right? So this process of blood and formed element development is called hematopoiesis. This is from the Greek root heme, which is blood, and poiesis, which means production. So hematopoiesis is the development of blood components, the formed elements of blood. So again, we are looking mostly at red bone marrow as our site of hematopoiesis. Before birth, it's actually occurring in a wider number of tissues, starting with the yolk sac of a developing embryo, but also as a fetus develops, hematopoiesis will happen in the liver, spleen, some of the lymphatic tissue, and then later on in development starts moving into the red bone marrow. After birth, it is going to be pretty much exclusively in that red bone marrow, especially in adults, mostly the cranial and pelvic bones, as well as the vertebrae, sternum, and the proximal epiphysis region of both the femur and humerus. In adulthood, the liver and spleen do keep their ability to generate the formed elements. This is called extramedullary hematopoiesis, so blood development outside of that medullary cavity of the adult bones. And so that's usually only going to happen if there is something wrong with the bone marrow itself, but it's not really going to be able to generate the number of cells actually needed. So, looking in that red bone marrow, again, we start off with those stem cells all the way at the top of this flowchart. These are multipotent hematopoietic stem cells, also called hemocytoblasts. So if you haven't noticed by now, hemo refers to something having to do with the blood. So a hematologist is somebody who studies the blood. Hematopoiesis is development of blood, so on and so forth. So these stem cells, again, can undergo mitosis without that cytokinesis, that cellular division, and so that allows them to be able to further differentiate into any of these other cell types. And so the hematopoietic stem cell here, or hemocytoblast, is that first step in the development of blood cells. Obviously, there's going to be more levels of stem cells above that, like the totipotent and pluripotent stem cells, especially early on in fetal development, but those need a lot more signals, chemical signals from the body, like cytokines, to signal them into certain pathways. So this process, hematopoiesis, starts when this hematopoietic stem cell gets a chemical signal from a bunch of chemicals collectively called hematopoietic growth factors, which trigger this to actually start that mitosis process. When we start that, we are going to keep a daughter cell, multiple daughter cells, but one of those will remain that hematopoietic stem cell so that it can keep generating this hematopoiesis process. But the other one, produced by that mitosis division, is going to get other signals to start differentiating into one of these two main pathways, either the myeloid pathway or lymphoid pathway. So as you can see, the myeloid pathway will produce the vast majority of our formed elements. The lymphoid pathway is going to only produce a couple types. So this is going to give us our lymphoid stem cells and then lymphoblasts, which then differentiate into natural killer cells, and lymphocytes themselves, which then further differentiate into our T and B lymphocytes. B lymphocytes can further differentiate into plasma cells after an infection. These are going to help with some of our antibody production and stuff like that. And so those are all really, really important. But these start out developing in the bone marrow and then migrate to the lymph nodes, spleen, and thymus, where they finish out these later processes of differentiation. Myeloid stem cells can further differentiate megakaryoblast, proerythroblasts, and myeloblasts. So those megakaryoblast will become megakaryocytes, which are the main cell type that are pinching off little pieces to produce our platelets. The proerythroblasts become reticulocytes and then are red blood cells or erythrocytes. And then myeloblasts can further differentiate down this way or to monoblasts. So myeloblasts can differentiate directly into basophils, neutrophils, and eosinophils, or they can become a monoblast, which will become a monocyte. And then again, once that monocyte leaves the blood vessels and enters the tissues, it becomes a macrophage. So there's a lot of different chemical signals, those hematopoietic growth factors at various points of this process. So one really important one that we touched on with the endocrine system was erythropoietin, or EPO. This is made in the kidneys because we have really low levels of oxygen, and so that signals the bone marrow to start producing more erythrocytes, and so that's going to trigger this pathway down towards the erythrocyte production. We talked about EPO being a banned substance in a lot of professional sports and stuff like that, because it can be used as a performance-enhancing drug to increase the number of red blood cells present and oxygen delivery. But it can also be used for good purposes in a medical setting to treat certain types of anemia, especially those triggered by cancer and stuff like that, where we do need to up those erythrocyte numbers. Thrombopoietin is produced by both the kidneys and the liver and will trigger our platelet development. And then cytokines is a big group of chemicals. Cytokines means cell movers. So these are chemicals that are triggering a lot of cellular movement to various areas of the body, but also help trigger some of this hematopoiesis. And so they get produced in a wide variety of areas. The bone marrow by actual cells themselves, as well as endothelial cells and stuff like that. And so they will stimulate some of these earlier cells to start differentiating and start triggering some more specific and generalized responses to various diseases. We have two main types, colony stimulating factors and interleukins. Colony stimulating factors are going to trigger the myeloblast pathway of development, so that we're getting all of these basophils, neutrophils, eosinophils, and monocytes. But they can also help trigger erythrocyte and platelet development in addition to those, but not at as much of a level as the erythropoietin and thrombopoietin. So there are certain types of chemotherapy patients that will actually be given synthetic forms of colony stimulating factors to help get their bone marrow to keep up with making these different types of white blood cells so that they keep their immune system functioning as best as possible. And then interleukins, the other class of cytokines, are still important in hematopoiesis. They were thought originally to be exclusively for communication between the fully developed and matured cells during infections and tissue damage, but we do know that some of them also get produced in the bone marrow and endothelial tissue. To help trigger some of this maturation of the different cells and stuff like that. But that is still early on in the stages of research, so we do need a little bit more information to know exactly what's going on. So again, all of these happen in the bone marrow. So a bone marrow biopsy is a diagnostic test to look at what we're seeing as far as these earlier stages of cells that are actually in the bone marrow still. And so that can tell us if there's maybe an overgrowth of one particular type that we should be concerned about. And then bone marrow transplants is when all of the bone marrow of somebody who usually has a type of cancer, a leukemia or lymphoma, mostly leukemias, will use chemotherapy and radiation to kill off their bone marrow completely because it's producing cancerous cells. And so we need to stop that cancerous cell development. And so if we kill all of their natural bone marrow off, we can transplant a healthy donor's bone marrow into them, and that will replace that faulty bone marrow. And so that type of treatment can be really helpful for, again, leukemias especially, but also thalassemias and sickle cell anemias, which we talked about a couple videos ago. So really severe forms of certain types of anemia can be treated that way as well. And so this procedure is really painful, unfortunately, but sometimes if you're faced with a life or death decision, then a little bit of pain is worth it to get healthy again. I actually have a couple cousins who have had bone marrow transplants because they had leukemias starting to develop when they were little kids. One of them got really sick. It took a while for them to diagnose it. The other one, they was the younger child and they knew to test for that already and were able to start treatment much sooner, and both of them are healthy and happy adults now, which is awesome to see. And so this process of bone marrow transplant still requires donor matching because there are still going to be some immune cells out in the tissues already, so we don't want to kill that off. But that's going to be treated very similarly to an organ transplant. Interestingly, there have been cases where somebody's genetics, so somebody could have a blood test done for something genetic and actually come back as matching an entirely different person, whoever that donor was. It's been seen in a couple criminal cases and stuff like that. You can definitely Google that if you're interested, but that does happen if we are fully replacing the bone marrow of a particular person. And that wraps up this video. We will finish up talking about blood typing in our next video.